We go. Yes, but first of all, we hitch a ride on mom's erythrocyte, because that's where it all starts. And we load it up with oxygen, and we travel down the descending aorta, the common iliac, and the internal iliac towards the pregnant uterus. And there, nature or Darwin or God have done us a tremendous favor by building the uterine artery in a way that it crosses over the external iliac, an extremely useful feature when you're searching for it. Christoph Lees just has shown some wonderful video clips, so we just move on to the next one, because this, over the past few years, has become one of our most important diagnostic tool, and we're all there sitting and looking out for the notch, and the notch is a visible downward break of the continuity from systole to diastole. Now, there are unfortunately a bit too many indices, and the problem is we still have not really come to an agreement what index is the best one to use in the uterine artery, because the conventional PI that we use more or less swallows up the notch. The notch is just factored in, and even a big notch will hardly, if the diastole is high in the end, which can occasionally be the case, the fact that there is a notch is swallowed up by the PI. There are some special indices, notching indices, but which are used only locally, difficult to get accepted in publication. So there has been an ongoing debate on what the ideal way to measure the uterine artery. And this is so important because at the moment we are struggling with a blurred diagnostic concept that mixes screening for preeclampsia that might manifest in a couple of weeks' time and actual diagnosis of dysfunctional maternal blood flow patterns, possibly causing fetal growth retardation. Now, large multi-center studies, systematic reviews have shown that a notch and or an increased PI at 19 to 24 weeks, I still use the German one here I noticed, are predictive for later development of preeclampsia. Now, this is wonderful, but what do I tell the patient? Do I give her aspirin? Do I demand weekly exams? Do I tell her not to go on foreign trips or not into the forest where her mobile phone isn't working? We still have not moved very far away, and we're still very much in the position of the gypsy woman and her crystal ball. Now, we have left the mom's uterine artery, and we're about to deliver our oxygen. So we came here below. These frisbee-type things are the erythrocytes, and our oxygen is moving here through the placental membranes. Remember all these features, the Golgi apparatus, mitochondria, vacuoles, etc. And up here, these fellows with a red spot in them, these are the fetal erythrocytes. Fetal erythrocytes have a nucleus. Adult erythrocytes do not have a nucleus. And it's onto these fetal erythrocyte where we have a hemoglobin that has a very high affinity to oxygen. It's to these that we deliver our oxygen. Now, we humans have a hemochorial placenta, and we share that with rabbits, rats, and tenrecs. Anybody knows what a tenrec is? Ever seen one? It's these animals, they're little hedgehogs that live in Madagascar. Nowhere else, are not related to our hedgehogs, and somehow they have developed the same placenta as we have. All other experimental animals, sheep, dogs, cats, etc., goats, they all have a very different placenta from ours. One of the problems of finding good analogies in animal research. Now, I found this in a school textbook a few years ago from friends in London. That 12-year-old son was trying to learn the fetal circulation, and you see here, that's us. You know, we are moving across in the bus, and the bus is the fetal erythrocyte that is taking us up into the fetal circulation. And now we really have to fasten our seat belts, and because we're inside the fetus. And the first part of our trip, of course, takes us through the fetal heart. first of all through the umbilical vein, where we glide smoothly along, and then it becomes really tight. I noticed there are two participants from Switzerland. Where is this? Yes? Yes, it's the Rhine Falls of Schaffhausen. The whole Rhine falls about 30 meters down and creates incredible rapids, sprays and everything. And amazingly enough, the same thing happens at the point where the umbilical vein enters the baby's body at the navel. So never, if you do umbilical vein Doppler, never look there, because you're always going to get very confusing, sometimes on the verge of turbulent picture. If you're doing research on it, wonderful, that's the place to look. But if you're just looking for the umbilical vein, let's say in a compromised fetus, don't look at the umbilical insertion. And Kielewitz has called it the first rapids, where the first time this blood is really tumbled and thrown around. And then we come to the big distributing point at the liver. And we have Torvid Kieseroth here. He will talk much more in detail about this. And from this point that the umbilical vein, which is inside the body of the fetus, reaches the ductus venosus, it passes from the continuous to a pulsatile flow pattern. And blood and we on the erythrocyte have been trundling along peacefully at 10 to 20 centimeters per second, and suddenly we really speed up. We go to 60, 85 centimeters per second, which is the highest velocity in the venous system. And Torvid has developed a fantastic concept about how the kinetic energy needed to build up so that the blood can throw itself through, inject itself towards the foramen ovale of the heart. Now, the A wave, many of you who do ductus venosus Doppler, I'm sure all of you who do, those who do ductus venosus Doppler, have been taught to look out for the A wave, which is a pressure, which is the result of the pressure resulting from the atrial contraction. And the rule of thumb is the deeper the A wave, the more compromised the fetus is. Here again, something that will be developed more in detail by Torvid Kieseroth, the crista dividens in the heart, which we suppose is meant to divide the blood between a more oxygen-rich flow towards the foramen ovale and the left ventricle, and a less oxygen-rich towards the right ventricle. But of course, also the right ventricle cannot only use the detritus of oxygen-depleted erythrocytes, it also needs the spillover to support the rest of the body with oxygen. We pass through the heart, through the foramen ovale into the left atrium, or if we took the other way, through the tricuspid valve towards the right ventricle. The classic concept of the via dextra and via sinistra, and Torvid will develop this further, is that good oxygen-rich blood passes through the umbilical vein towards the ductus venosus, and circumventing the right atrium passes directly into the left atrium, the left ventricle, through the foramen ovale. And after the coronaries and the brain have extracted all the necessary oxygen they need, then the blood goes back for a second round in the right ventricle, and from there to the rest of the body. This is one of the pictures we used in Rotterdam. I think you can see from the image it's still pretty old. It's already has a certain old-fashioned feel, but whenever you put your Doppler over the fetal heart, and remember this is not a cardiac course, some lectures will be tomorrow by Giuseppe Rizzo on the heart, but basically we are concentrating on the non-cardiac application. It just gives you an idea of how really confusing it is, as if looking at a busy traffic crossing with very heavy traffic in all directions with ingoing and outgoing blood all superimposed over each other. Now, we are taking the via sinistra and we shoot up the aorta on our erythrocyte. Here, we are here, and these are the vessels leading up to the heart. This round structure here is the esophagus, which was only drawn in as an orienteering structure. Up the aortic arch, and all that blood from the left ventricle that is not used to supply the coronaries or the brain or the upper extremities goes through a very interesting, very small but very interesting structure, which is the isthmus of the aorta, that then merges with the blood coming from the ductus arteriosus. And the concept is, I took this picture of the Japanese plane a few years ago. I put this in not knowing that this nowadays would have a different significance. An early warning type system for fetal hypoxia, because during fetal hypoxia, blood flows upwards during diastole, and the more upward flow, the worse. And Fouron from Canada has developed this concept, saying that an equal amount of blood reaches the brain, but its quality in terms of oxygen content decreases through the mingling of blood from the reverse flow part, that's in violet here, part of the aortic isthmus wave. So in a deteriorating fetus, some of the part going through the ductus moves up here, and this is something you can measure if you're really good at isthmus measuring. Now, the great shunts of the vessel and what makes fetal circulation so fascinating are the watersheds, that the fetus has structures we do not have, where we can move between, decide where to put the blood, where to put the oxygen. All over Europe, you have signs where if you pee on the left side, it will go towards the Rhine. If you pee towards the right side, it will go towards the Black Sea or the Adriatic. And the same is happening all over the fetal body. Now, in the 80s, the first Doppler publications were done, and we looked at the common carotid artery, which was one of the many wrong turns we took over the years. But nowadays, blood supply to the fetal brain is also something we have come to use in everyday routine. And basically, we are interested in one vessel, the middle cerebral artery, and we look for two things. If there's a high diastole, we call it brain sparing, and if there's a high systole, we suspect anemia. High peak flow velocities in the middle cerebral artery are very indicative of anemia, also something that has over the past 10 years found very widespread application. And under hypoxic conditions, the vessel diameter and the blood flow volume in the brain increase, and the Doppler indices and the PR/IR decrease. Brain sparing is the concept that in order to get the sparse oxygen to the brain, there isn't much oxygen around, so the brain has to throw open its vessels to allow more oxygen in. Now, Siko Serjon from the Netherlands has done long-term follow-up on children who had brain sparing in the 1980s. They're over 20 years old, and he tests them regularly. And all these are very severely growth-retarded fetuses. And when they were in utero, brain sparing favors a better outcome in motor development, but children exposed to brain sparing in utero have a worse cognitive outcome. And we're still unsure as a whole professional group when to draw the line, when is the right time to end a pregnancy in a seriously compromised IUGR fetus. And we have just finished recruitment for the truffle study, so maybe in a year and a half we will have a better answer to this question. Now let's get back, we're still on our erythrocyte, and we go back to the heart through the cerebral veins. And also these cerebral veins, they're influenced by cardiac contractions and look quite similar to pulmonary veins and the ductus venosus. For about 5 or 6 years ago, we were all very interested in the cerebral venous circulation and hoped to find something akin to the ductus venosus of the early 90s, but until now we have not been very successful. We come back to the heart. We go through the right ventricle into the ductus arteriosus. Now we all know that the ductus arteriosus obstructs and closes shortly after birth. Very few of us, I assume, still have an open ductus arteriosus. It should all look like this, as on the right side. And when the ductus arteriosus constricts in utero, then the flow curve gets too fast. Now, when do you need to do ductus arteriosus Doppler? In case that in your department there is a habit of doing emergency tocolysis within the medicine, very effective but slightly dangerous practice. But also when you have accidental intake of indomethacin by pregnant women who searched the bathroom cupboard for a headache medication. We have a whole generation of people who have grown up with a concept that for whatever unwell feeling you have, you just grab something and swallow it. And unfortunately, some of these women also carry over this behavior into their pregnancy. And they also have patients who only take holistic and alternative medication. And a few years ago, the Belgian police raided a few health shops selling Asian concoctions, and in a syrup recommended by Ayurveda medicine from health shops in Brussels, specifically for pregnant women, they found phenacetin, cortisone, and indomethacin in it. So there's always a latent danger that your patient has ingested something that will constrict her ductus arteriosus. Hanadi Awadeh, one of Rabbi Shawi's PhD students, has made this beautiful case report of a woman who had a Vmax of 330 centimeters per second. Personally, I've never seen such a fast one, but here is the proof. When she had emergency tocolysis with indomethacin at 31 weeks. And fortunately, most ductus arterioses are flexible. They do not stay constricted, but they loosen up the moment you stop the medication. And here, after 1 week, it was back to normal with a Vmax of 140, which is normal for ductus, and a PI of 3, up from 0.6. So ductus arteriosus is one of the vessels where you're really happy and satisfied when they have a very, very high PI. Now, the ductus arteriosus and the descending aorta merge. We have been on this place before. It's the area that Furon is so interested in. But from this point onwards, placental impedance or resistance determines what our Doppler curve looks like. We're down the descending aorta, and here is something that the Swedes, who have given us ABBA and IKEA, and they've also given us blood flow classes, the Swedish alternative to indices, which were developed at a time when it was very difficult to measure indices on the ultrasound machines. They were very inexact, they gave wrong numbers. So Marcel and his group had the brilliant idea of simply standardizing the eyeballing procedure that everybody does. Most of us who have routine in Doppler do not wait for the PI or RI to come out. They look at the umbilical waveform and know if it's good or bad. So back in the back of our minds, we all do blood flow classes. And in Sweden, they have standardized this. Normal, 1, 2, 3, 3 with a reverse flow component. Now we leave the fetal body on one of the 2 umbilical arteries and we head towards the placenta. 95% of all obstetrical measurements that lead to things that affect obstetrical practice and decision making are taking place here. Also a picture, this one from Titia Cohen from Rotterdam, on a severely growth retarded patient where something done in Holland called the non-interventiebeleid, the non-intervention procedure was performed, and you see still slightly acceptable pattern at 24 weeks, a zero flow at 27 weeks, some slight reverse flow parts at 28 weeks and serious reverse flow at 29 weeks. Also rather old, I think they are more than 10 years old, but still of tremendous didactical value. This is the way it proceeds if you do not intervene. Now, of course, the worst case scenario, and I'm sure you're all familiar with it, is reverse flow, that placental impedance is so high that during systole blood flows upstreams in the umbilical artery. Now, reverse flow as such is not an evil or bad thing. If you take the transducer, put it on your thigh and look in your inguinal area around towards the femoral arteries, you find that with every blood stroke you have, you also have reverse flow. It's quite normal because we have elastic vessels in our peripheral arteries, but in the fetus, in this special construct with the placenta, reverse flow is a very, very bad sign. And simply taking one part from Christoph Leaves, just one technical advice, don't put the high-pass filter too high. Now, the high-pass filter on our machines, they are not for us obstetricians. They are for the neurologists and for the cardiologists who need to get rid of the background noise of the elastic arteries that are blurring their picture. We obstetricians should not activate the high-pass filter, never go higher than 100 hertz. They're also called wall motion filters. And in this case, then it looks, you recognize it, suddenly you have something like a black stripe here, and that can become dangerous. Now, we are a bit stressed for time, as the previous talk took a bit long, so I've speeded up. I've become slightly tachycardiac and high velocity flow in my speech. We're diffusing back to the maternal side. This is us again. And what we sum up, what we learned on our round trip. Depending on localization, the flow pattern is influenced by contractility of the heart, cerebral autoregulation, the ability of the ductus arteriosus to squeeze shut, and the quality of the placenta and its interface of the uterus. We're all very much focused on this area. This is what we think about. But we should never forget the three other ones, and this one will also affect contractility, cerebral autoregulation, and things you might accidentally or intentionally do to the ductus will also influence a lot of your flow patterns. And the last message is, even with the best 4D color Doppler stick, etc., power machine, never forget good old basic anatomy, because that's where the action is taking place. Doppler is a vascular technique. You need to know what the vessels are, where they come from, where they go to. We need to understand how evolution or God or Darwin had intended them to be, and from that we can make our deductions. So in case you found this too simple and you feel like Obelix being really upset that he has to learn these basic things, I can assure you a lot of interesting lectures to follow. Keep listening and learning. We have to do this all the time. Thank you.